Hi, guys. Welcome to A Little Help for Our Friends, a podcast for people with loved ones struggling with mental health. Hello, little helpers. Today, I have a really interesting episode. And I'm fascinated by it because it touches on a controversy that I am just learning about. And it is a heated debate and discussion in the field of mental health around borderline personality disorder, BPD, and complex PTSD, complex post-traumatic stress disorder. So I'm going to try to summarize the controversy for you, and I'm just learning it myself. So if you have difficulties with emotion regulation, right? Like you have big emotions up and down, a lot of negative emotions. You have problems in your relationships. Maybe you self-harm or you have suicidal thoughts or actions. And you also have dissociation, meaning kind of blank out when things are really, really stressful. Well, to me, I always thought, well, that's a diagnosis of borderline. Those are traits and symptoms of borderline personality disorder. But lately, I've been seeing that that is sometimes really insulting to some people, really upsetting, because borderline personality disorder has so much stigma around it. And I think people just assume that it means that, that you're broken or wrong or that it's your fault. So that's the controversy that I'm understanding is that people are really upset by the BPD diagnosis and they want CPTSD, or they want the diagnosis being more recognized. But at the same time, I think that they're different disorders, or like, how do we treat both of them, or are they really interchangeable? So I talked to Kaytlyn Gilner, who is doing her master's. She's completing her master's in social work. And she is a mental health advocate and host of Not So Dumb Blonde podcast. So she is so cool because she really loves to explore women's mental health and trauma and relationship patterns. So it's like all the stuff that I love. And her work is rooted in both lived experience and her clinical training. It's, again, so much overlap. And she really is passionate about helping women understand their emotional expressions, validate themselves, navigate relationship dynamics, and heal from complex trauma. And she's super passionate about breaking the stigma surrounding diagnoses like borderline personality disorder. So she she talks a lot about CPTSD and how healing it could be to get that diagnosis, but also she's on board with let's not stigmatize BPD. Let's not say BPD bad, CPTSD good. It's like, let's understand these disorders and figure out what tools can help them. She also creates like really cool practical tools. Like she has a DBT, Dialectical Behavior Therapy inspired workbook to help people, especially women, apply emotion regulation and self-awareness skills in their daily lives. Kaytlyn just reached out to me on Instagram, said, "Hey, we're talking about similar topics. Let's collaborate." So I went on her podcast, and she came on this one, and it just led to a lot of really interesting nuance conversations about if you are struggling with relationship problems, emotional problems, dissociation, self-harm, like, what do you have? And also, does it matter? And what treatments do we want to give them? So we talk a lot about that, but I really appreciated her thoughtfulness about this. And I really resonated with her personal journey of having all these symptoms herself and struggling with it, and being in the place of being a teenager and having to be diagnosed with something, and then getting some help for herself, getting DBT, and then loving it so much and seeing how much it could transform people's lives that she's becoming a DBT therapist now. So it's such a inspiring story. It really speaks to whatever you have. If you have CPTSD, BPD, whatever acronyms, letters you want to throw out there, it really is about understanding what you're going through, understanding your experiences, finding the help that you need, and building a life worth living. both Kaytlyn and I have been through a lot of childhood trauma. And so we have a lot of these, these traits, symptoms, whatever you want to call it in the past, but now we are becoming or are therapists and working with this and helping other people who used to be like us. So it's just it was just a really wonderful conversation to have with someone who is also passionate about what happens when people fundamentally have a hard time sitting with their feelings or intimacy. And if you are listening to this and you have a loved one who is struggling with borderline personality disorder or CPTSD or any other mental health problem that is impacting your lives, please look into Kulamind, KULAMIND.com. That is my program for loved ones of people struggling with mental health. And it's where you could work the most with me. I do skills groups for loved ones. There's community. There's all these different tools. And basically, I walk you through the different skills that could be super helpful for loving someone with these conditions, like setting boundaries and validating, taking care of yourself. So if you feel like you need that, Kulamind.com, KULAMIND.com, and you could just book a call with me and we could talk further about what you need. I hope you enjoy this episode with Kaytlyn Gilner, and check out her podcast, Not So Dumb Blonde podcast, after you listen to this episode. Enjoy. Welcome back, little helpers. Today we have a really special guest. Her name is Kaytlyn, and she is. Are you doing your master's? You're in your master's?
Yes, I'm finishing it. I'm in my last year.
Oh my God. Oh my God. So Kaytlyn is getting a master's in social work, and she is a mental health advocate and the host of Not So Dumb Blonde podcast, where she explores women's mental health, trauma, and relationship patterns. So we have a lot of overlap in what we're passionate about. And I'm so excited I'm so excited that you reached out and, we're having these conversations because we're talking today about complex PTSD, post-traumatic stress disorder, and borderline personality disorder. Hot topic that I had no idea about until I got online as an old lady being like, how do I TikTok? And I just really want to understand the controversy around it. What's going on? Why do we hate one and like the other? Why are they the same? Why are they different?
Totally.
So just lob it to you. What is your perspective on CPTSD and borderline personality disorder, BPD?
Yeah, I'm so excited to talk about this because like you, this is something that I've seen circulating around everywhere. I've seen so many people talk about it, and sometimes I just feel like it's important to talk about because I feel like sometimes we're just missing the point. And really, my work is mostly rooted in both lived and clinical training. So how it came about for me and just a little bit of background story as to why I'm like passionate about this and why, like how I view the scenario. Younger, around 14, I was repeatedly misdiagnosed with things like BPD and bipolar disorder and ADHD. Nobody really understood what to do, but you have to remember, I was like between 12 and 14 years old. That's a really early time to diagnose someone, right? And what's really interesting is that nobody was asking what was happening behind closed doors. It was actually me experiencing significant trauma, and I just didn't have the support that I needed. So what I did was I really started internalizing that I was the problem. And I think that that's a common theme. And I think that that's why this is such a hot topic, right? And it just kind of made me feel like there was something fundamentally wrong with me. And that, followed me for a while throughout early adulthood until I got into therapy and DBT, which I'm sure we'll dive into because we both love it. And that's kind of how I really got into this because a big part of my transformation was learning the practical tools and just really diving into that and making sure that, so when I was little, I told myself, I was like, when I grow up, I'm going to help people like me. I'm going to help women like me not feel misunderstood, right? And feel confident in how they feel without feeling like they need to change it or there's something wrong with them or they're too sensitive. So very long explanation to say, the whole BPD and CPTSD diagnosis, I think kind of goes back to that. It's, when I was younger and I heard them talking to my mother in the waiting room, they said, you don't want her to have that diagnosis. It'll ruin her life. And yes, it'll ruin her life. Nobody will want to work with her. She's not going to. So as a young kid hearing that, I was like, I'm not normal. I became like agoraphobic. I wouldn't leave the house. I was bullied. I mean, I fundamentally thought there was something wrong with me. So part of that, right, is breaking the stigmatization of what BPD really is and recognizing that BPD is real and so is CPTSD. While they're separate, there's a lot of overlap. So while diagnosing can be helpful for some people, it's not always, helpful for everyone. But just ensuring that we kind of know the difference and also just have some, I guess, humanness and gentleness around the topic, I think is important.
Yeah. Yeah. Wow. Tell me a little bit about whatever you're comfortable sharing. What did that feel like and look like for you from 12 to 14? Like, or that
Yeah.
time period where,
Yeah. I mean, honestly, I was highly isolated. I had a bit of a chaotic family life and home life, and there were, some things going on. So basically, I kind of took the brunt of it all and took it on as like, I'm too sensitive. Like there's something fundamentally wrong with the way my brain works. And that was kind of ingrained in me at a very, very young age. Right. And so, yeah, I mean, those were some of the feelings that were kind of coming across. And like I said, I just remember being like, when I grow up, I'm going to help other adolescents and, women who are going through this because I knew it was wrong. I still knew it was wrong.
yeah, that makes sense. I mean, I had a very similar background. Sorry, we didn't talk about this before, but I also had, chaotic, dysregulated household with a lot of addiction, a lot of pain, and my mom and I were fighting all the time. And I would fight with my boyfriends, and then I would self harm because I didn't know what to do with all these feelings. And I, at that time, like a teenager, I probably looked like no, I did. I probably met criteria for most of the BPD traits. I was young, and my therapist said, yeah, you would have met criteria for a lot of the traits, but like whatever. And
Same.
now it's a little bit different. So, yeah, how do you resonate more with the CPTSD diagnosis? Or tell me, well, first of
Yeah.
all, tell people listening, what
Yeah.
are the different disorders?
Yeah.
How do you think about them?
Yeah, totally. So I know I went off on a whole rant earlier, but really, so, I had seen a lot of things on TV too about like Jodi Arias is a perfect example. I don't know if you've heard of her. She had killed her boyfriend and they were like she has borderline personality disorder. And same with Amber Heard, right? And so I had felt like I resonated with some of the traits when I was younger. And so seeing those headlines, I was like, "Oh my gosh, it's happening again. Like there's something wrong with me." But I had gone through the work. I did dialectical behavioral therapy. I don't meet the criteria, but I still like I can understand the criteria. Like I understand it. And there are some things that I can resonate with on a much lower level now. That's when I was told by the one therapist that actually listened to me. She said, "You have CPTSD. You do not have BPD, like at all." And I was like, "What is CPTSD?" And it changed my life because it gave me the confidence because I was like, I'm not disordered. I'm not disordered. I went through stuff that I didn't deserve to go through. And I'm trying to adapt and learn how to live with tools that look much different from individuals who don't suffer from that much trauma, right? But we live in a society where we're not rewarded for that or for being highly sensitive. And so that was a huge awakening for me. And that's kind of what kickstarted my whole journey into therapy and doing the work and learning tools that really work and seeing that healing is really possible. Because a lot of times the message is for individuals with BPD, which is not accurate. The research fundamentally disproves this, but it's that you cannot be cured or treated. It's not true. It's very, very treatable. And so another long way to answer your question is, that there are differences. There's a lot of overlap. CPTSD is complex post-traumatic stress disorder, chronic post-traumatic stress disorder, right? So a lot of times individuals with CPTSD, one of the common traits is that they don't know when their trauma began and when it ended. There's no like beginning or end to it. It's kind of like, this is just how it always was. So that's like a very common theme with CPTSD, right? And the difference, I would say, as they have a lot of the similar traits of, the hypervigilance, kind of roller coaster relationships, some of that feelings of emptiness or sometimes paranoia. But CPTSD has a little bit more of an avoidance to it, a more of a numbing out. And BPD has that very core trait of abandonment. It's very like abandonment.
Yeah, That makes sense. That makes a lot of sense. What for you resonate? Like, I'm so glad you found the diagnosis that, gave you that feeling. I mean, I'm, I'm like, I'm having all these thoughts. I'm just like, why can't people feel that way when they get a BPD diagnosis? Like, why, like, when you're like, oh, it's a disorder, it's something that happened to me, it's not my fault. I'm like, yeah, same with BPD, right? Like, it's like,
Yeah.
it's, I mean, again, I'm saying this more and more now, but I feel like I was really, really privileged with being in research and clinical centers where everyone was like, yeah, BPD, we know what it is.
Yeah.
Totally fine, totally treatable, not a bad thing. And that's not the case. So what CPTSD diagnosis, like when you talk to your therapist, what was it that went, oh, this feels more like me? Or is it just kind of recasting of the experiences you were having into a different label?
Yeah. No, that's such a good question. Before I answer that, I want to go back to what you said because we kind of touched on this the other day too is, yeah, why can't individuals who do get a BPD diagnosis have that same feeling, right? Of like it's not their fault. And it is because of the stigmatization online, but it also starts with having these conversations like what we're having now and being like, I mentioned to you the other day, we had a little bit of a side conversation and it was, I've been told, on the internet that using the term BPD just in general is offensive to even say that. And to me, I'm viewing that as like, wait a minute, that's part of the stigmatization is treating BPD like a dirty word or a dirty thing to say. It's not. It's absolutely not. But, for individuals who may resonate with some of those traits, as we know, and as the research shows, is that shame is a huge part of it. Shame fuels a lot of BPD as well, right? And some of the reactions. So for me, getting the CPTSD diagnosis, being told, basically my whole adolescence that like, you're not normal kind of thing, it kind of just made me feel just validated. Like,
Mhm.
the experiences I went through as a child, because I think us as women, we feel oftentimes there's a societal pressure to just minimize everything and like keep it all together and not like talk about those things, right? Or when we do talk about it, it's like keep it lighthearted, don't make anybody feel uncomfortable. And having that told to me was like, wait a minute, no, you did experience trauma and you can't like deny that anymore. That's something you have to look at and kind of accept. You can't keep pushing it down because that's part of the problem. It's accepting that like you kind of lived a life that you didn't really want to, like you probably wouldn't have chosen to live in if you had the choice.
Yeah. What is it like to have to accept that? I mean, I imagine like there's part of it that feels really freeing or validating, but at the same time, that could come with like a whole shift in the way you were seeing yourself and your childhood. Like, what was it like to be like, you have trauma?
Yeah.
You've been through trauma.
There was a lot of grief. There was a lot of mourning of the life that I didn't have, that I didn't realize was abnormal until I got a little bit older and realized and saw some of my other friends. And you start mourning this idea of like what you could have had. Or, looking back for me, I'm like, I remember very few moments of like having that childhood feeling. And it was before the age of 12. And that is sad, not being a kid, but it came with liberation for me, to be honest, because I found DBT. And that's why, for listeners, I don't know if we said this earlier, I am getting my master's in social work and I am on the road of becoming a therapist. I'm going to be working, in a DBT clinic here starting in the fall. I'm very passionate about it. Yes. And it's because it changed my life. It's not just because I chose DBT because it's, the gold standard for BPD and what I also think it's great for CPTSD, despite what some things are circulating online. So that gave me hope. And it kind of gave me the tools to not, before there was a little bit of like a victim complex of like, why is everything happening to me? And then having that realization was like, wait, I can take the power into my own hands now. Like I can do this.
Wow, that's amazing. And I also have been thinking about this, can BPD or CPT, like, can any of these problems actually change, right? Some, especially people who are struggling with it, especially people online, are like, can this be treated? Is this curable? And you're giving such a beautiful example of like, yeah, there's a lot that can change, right? It's getting the right diagnosis, right understanding of what you went through, the tools, the empowerment, like I can do something about this. Do you have a moment in DBT or skill that was like, the light bulb moment, or
100%. I think about it all the time. And before I say it, I just want to say one other thing. Like this idea of needing to be cured or healed or fixed. One of the messages that I'm pushing in my mission is to make sure that people know, and in particular women, because that's my target, that's who I mainly work with. You don't need to be fixed. Like, even if there are patterns and behaviors that you would like to work on to be healthy and express your emotions healthily, how you're feeling, and even if it resembles traits of borderline personality disorder or yet disordered thinking, there's nothing wrong with it. You don't need to fix it. However, if you want to have healthy relationships, you have to change how you express how you are feeling. And that is just the way it is, and the choice is yours. But I don't want people to feel like there needs to be a cure or because there doesn't. But going back to your point with DBT, opposite action, I mean, hands down, because for me, I'm very, I always have like 1,000 to-do lists, and I'm like the self-aware girly who's like doing yoga, and it becomes a lot when you're like, okay, I'm going to add a new skill that I'm going to try to learn. And so for me, opposite action, what I think is so beautiful about it is that it doesn't feel like an extra thing I have to add on to my self-care routine. It's just in the moment, just flipping one mindset to another. And it really did change my life because when I was younger, I definitely leaned a little bit more on the anxious side, right? And, as a highly sensitive person, of course, and, perceiving the emotions of other people when you're highly sensitive can be hard. And a lot of people's reactions are either to withdraw or to, try to pursue or soothe or fix. And so I just remember one day, and this was before I actually got DBT training. I just was like, I'm just going to do the opposite. Like, I'm tired of what I've been doing. I exhausted myself. I was like, it's just not working like anymore. And I just remember being like, okay, instead of like reaching out or trying to soothe or fix the situation or people please, I'm just going to sit back. I'm going to do the opposite. And I had immediate results from that. And so it was very easy to continue doing it. It didn't feel like work. It was like that actually got me to my desired place.
cool. When did you say immediately worked? What
Yeah.
can people expect from? So for people who don't know about opposite action, like when you have emotions, they make you want to do something, right? Like anxiety makes you want to run away, and anger. I was an anger girl, makes you want to fight, and it's about just literally doing the opposite of what that emotion is telling you. What worked? When
Yeah.
you sat back, what happened?
I mean, here's the whole thing, right? Like, if you have complex trauma or borderline personality disorder or BPD traits, there is a common paradox between wanting to push people away and also wanting them close to you at the same time. And so, like you mentioned, having that feeling of anger, right? What's really happening is there's fear and there's wanting to be vulnerable, but instead anger's coming out. And so that's pushing someone away, which is exactly what most individuals don't want and what they're trying to avoid. And so when I say it worked, I mean, I took a step back and I was like, you know what? I don't have to have control over this moment. I'm going to survive regardless. Like, I'll be okay. I'm going to sit back. And immediately, my partner and I remember when this was, it was in 2017. It's been a long ride. 2017, I was just like, my partner, he came to me in like a very calm way, and it just naturally was a healthy conversation, and we got stronger afterwards. And it was the first time in my life I ever experienced that. And so to see like, wait, this is possible. Like, this is possible. You don't have to push people away or be angry to get your point across. And I didn't know that because
Yeah.
I'd never had anyone respect my feelings or my boundaries.
Yeah. That's super cool. Oh, I'm so glad. Are you still with him, or was that someone in the past?
No.
Well, still, like, thank all of our teachers for all along the way. That's
I
wonderful.
learned a ton from him, though. I really did. He was great.
Yeah, I'm still working on this, but one major shift in my attachment, like my fear of abandonment kind of stuff. After a while, you forget that you have a fear of abandonment. Like, you're so good at like being self self-sufficient and whatever, that I didn't realize that I was getting so upset around when my husband would be sad or would be anxious or just be quiet. Like he would just be not, maybe just in a mood, and I would just freak out. I'm like, what is going on? Are you mad at me? And I just didn't realize that I had the assumption that it means that he hates me. He's going to leave me and this is all over. And not realizing that core fear was like bubbling up. I was like, I was leaning into, I was having thoughts of like, okay, fine. What is it like if we divorce? And how am I going to do this?
Immediately jump to the worst case, right?
So I'm just learning to sit back and be like, you could be in a mood.
I'm moving away.
I'm like packing my bags. All right.
Yeah, I get
Wow.
it.
That's really incredible. And what has it been like learning how to do DBT and work with these? Like, do you see a difference from a clinician side, the difference between CPTSD and BPD, or do they really feel like interchangeable, or what do you think?
I mean, that's the $1,000,000 question. I think that there is no black and white answer, and I'm going to tie DBT into that because that's really how I look at it, is that there's really no cut and dry black and white answer. It really can be very confusing to tell. And I think that it's important to note that, right? Because the research shows that a large majority of individuals with BPD have significant trauma, right? So, and then there's also the opportunity to be, diagnosed with both. And so how I view it now, being more on the clinician side, is kind of like I mentioned before, is I view, and this goes based off of, something I didn't mention, is CPTSD is an official diagnosis in the ICD-11. I hope it's ICD and not IDC. I think it's ICD-11. The International Diagnostic Criteria, it exists there, right? It doesn't exist in our criteria here, the one that we use, the DSM. I think that that's where it gets a little confusing, is like they kind of are somewhat interchangeable in my opinion, aside from a few different things. But the reason why is because we don't have CPTSD in the DSM, which is another thing that I'm advocating for a lot, is because I do think it's important to have, for proper treatment, for, proper diagnosis and stigma, to have both of them there so that we can properly decide what is what and what, individuals feel like they fit with the most.
Mhm. Yeah, definitely. I'm wondering, there is treatment for, I mean, a lot of like diagnosis. I mean, like, I don't know how you feel, but I'm like, whatever, who cares about the diagnosis, right? Like, it's just a checklist. I mean, whatever. It doesn't capture the whole person. It doesn't capture what they're struggling with. It's even crazy that you could have someone who is like self-harming and having huge anger explosions, but that's only 2 traits. And if they don't have anything else, they don't have a diagnosis. Like, but I always thought about diagnosis as a signal for what treatment do we choose. And there's really good PTSD or trauma related disorder treatments, prolonged exposure, cognitive processing therapy, and then there's DBT, right? How do you, if patient comes to you, they're having relationship problems, emotion problems, they've had a hard life. Where do you go? What diagnosis or treatment plan do you go for?
I mean, so for me personally, I'm a huge believer, and kind of like what you said as well. It's like treating the symptoms so that someone can live the life that they want to live. The diagnosis sometimes is helpful for some people, and for others, it's absolutely not, right? My number one thing is never diagnosing someone with actually borderline personality disorder, but really anything, without talking to them about what's happening in their environment. And that's social work 101, right? Like in my training, it's all about assessing the person in their environment. I have found that, some clinicians just go immediately to diagnosing. And I personally find that to be problematic, because it's really hard to sum up someone's personality and what's happening in one session or 2 or even 3. It takes time. And especially if you're diagnosing someone with like borderline personality disorder, it's labeled as disordered thinking. How do you know that without assessing long-term patterns and looking at what's happening in their environment? So for me, that's where I start, is what's happening in your life right now. Do you have a partner? What does that look like? how is that relationship? How is your home life currently? What is going on that has brought you here? And kind of diving into that more, because one thing that I found is a lot of times people don't know that it's their current environment. They just, especially women. And that's kind of why I have this podcast and why I jumped into wanting to become a therapist in the first place, is that, it's common for women to internalize things and blame themselves. And sometimes we need, and it doesn't mean that they don't need to take accountability. I mean, I used to get very angry. I still have a temper, but I learned how to manage it. And, but it's really about being like, hey, yes, you do have a lot of things to work on. And there's also things happening in your environment. You can't really heal in an environment that's making you sick. And so that's something that's kind of where I start. That's where I like to focus. And particularly DBT, I think DBT is great for everyone. It's tied to BPD because Marsha Linehan and how it was funded, the research and all that. But I would love to advocate for DBT as much as I can to kind of spread the awareness that it's a wonderful tool for everyone, not just for people who have trauma or BPD.
Yeah. Yeah, that makes total sense. That's so interesting. And starting with the environment, how does that change the way you see what their diagnosis is? Or because I'm thinking, like, if they have certain behaviors, right? Let's say they are self-harming, they're lashing out, they dissociate, all the things. If they're currently in an abusive or troubling environment or not, I still would probably, the diagnosis might be similar, right? The environment might explain what's going on, but I'm like, yeah, they have it. They probably went through something hard another time, or it's a bad fit. So how do you think about that environment, about like whether something's going on that they're reacting to versus like nothing's going on? It's actually my partner and family and home life are great.
Yeah. Yeah, I mean, I always like to ask, like, what was it like before? So, like, if the relationship is problematic. So it's more for me, like, if they do have a chaotic dynamic or relationship that they're in, or their home life or whatever's going on, what was it like before? Like, kind of going back to trying to assess some of that as well. But no, you're right. Like, you're right. And that's what I think is really important for everyone to know, is that as clinicians, and we are also humans, like there is no absolute truth, right? Our job is to support clients in their healing and get them to help them get to where they want to go, right? So I think that that's really what matters the most. And at times the diagnosis still does fit. I mean, especially if it's been pervasive over a long period of time. But I typically think that, if trauma was involved, and it says too, like in the DSM-5, that, someone should not be diagnosed with BPD if it can be better explained by something else, right? By another diagnosis, right? And so that's kind of where I look at the CPTSD thing. And again, it's not because I think BPD, there's anything wrong with it. I just think that it has been so stigmatized that it's so important for individuals I want to make sure they feel seen and heard, especially if they've experienced trauma.
Right. Right. That totally makes sense. That makes sense. Yeah. I mean, it's tough. It makes me rethink everything, because I always see the BPD diagnosis as good. Like, maybe I just have had so many experiences where, I mean, our whole clinic was like, love people with BPD, like even obsessed
Absolutely,
with it.
yeah.
And it's like, sometimes it could be relieving. I've seen it be relieving to get the diagnosis because they thought they had ADHD, and they thought they had a substance use and eating disorder and depression and anxiety, and they had like 10 different disorders. And to like make it into one, you have intense emotions and it's really hard to manage them. But it's sad that still has this like implied sense of this is who you are, and not a reaction to the environment or trauma.
Exactly.
I have a hard time, I have a hard time dealing with that.
Yeah. Oh yeah, just accepting that it is like who they are. Like
I just have a hard time accepting that that a CPTSD would have more of a validating, like, this is a reaction to the environment, than BPD. Like, I just don't like how people would feel that BPD is like, it's a you problem, and
100%.
not something that you went through. I'm like,
yeah.
like,
No, and I agree. And I will say too that, you're right. A lot of times people who do end up getting a BPD diagnosis have been misdiagnosed their whole life. And so to have an answer of like, wait, oh my gosh, like we know what's going on can be very, very helpful, for a lot of people. I think, where the for me on the flip side, something that I think about a lot as well is having these diagnoses can sometimes affect women in a lot of other ways, right? So imagine you're in a marriage and you're going through a divorce and you have BPD on your, like, as your diagnosis. The reason why I have a problem with it is that might affect decisions in the divorce process. Unfortunately, same with bipolar disorder, but when you throw BPD out there, and that's unfortunate, and that's kind of like the point that I think a lot of people are trying to get at is like, yeah, it shouldn't be like that. It shouldn't. But we live in a society still where we're working through breaking down some of those barriers. And so I think that that's an example I think about a lot. Like getting custody of your children, having that diagnosis. For example, going to the doctor, like research already shows that it takes women on average 10 visits more than men to actually be diagnosed with something other than it being psychological in their head. So when a doctor pulls up your charts and they see that you have this diagnosis, again, I'm not saying there's anything wrong with it. I think it can be very helpful, but I just think it's important to be careful with stuff like that. It can be shown, and that can affect how someone receives care.
Yeah, that makes sense. That's such an unfortunate part about society, where it's like if people don't understand, BPD on a chart can be like, oh, be careful of this one.
Yeah. Oh, yeah. And for example, I had therapists say to me, I was kind of like you, I mentioned, but I feel like I used to resonate with all these. And she was like, you might have in the past. And then she said, but I would toss that out. You're too self-aware for that. People who have, they're not self-aware. Even in my daily work with therapists that I work with or people in the field, even though the intentions are good, even statements like that are like, oh no, you couldn't. You're too self-aware for that. So like, you know what I mean? There's just
yeah
that goes around.
Yeah, implied that people with BPD don't have self-awareness, which they often don't, but that's
right.
That's
really exactly.
Yeah. Got it. As a emotionally sensitive person, what is it like to be a DBT therapist or working with this population?
It's highly rewarding because I think that also, individuals with BPD structure is really helpful for them. And that's what I love about DBT is how structured it is. And for me, I kind of look at it as more of like classwork or coursework, right? When you're doing it the traditional way, you're going through modules, you're not processing trauma. You're actually just navigating like, what are we going to do with this trauma? How are we going to effectively manage it in our everyday lives? So for me, I think it's very rewarding to see people start in practicing tools in real time immediately. And so to me, that's been very beautiful. And that's kind of why I've also created my own quick dialectical behavioral therapy inspired workbook for individuals, just so that, if they don't have the ability to dedicate that time, or maybe, it can be hard to find a therapist in real time, just having some tools to kind of work through in real time when you're trying to speak up and get your needs met, in particular in relationships, or set boundaries in a way that feels safe. I just think it's really helpful.
That's awesome. Oh, I'm definitely going to link that workbook to the show notes. So
please do. I love that.
That's super cool. I mean, it is such a shame how hard it is to actually get good DBT in general, right? Like, it's weird because the skills itself are everywhere online, but to actually get DBT, from a DBT therapist in a full model is different. Can you explain the differences about like, Googling or chat GPT versus like going to an actual like DBT therapist or?
Yes. And so I'm getting trained in DBT. My work is based off of DBT, but I'm not certified in DBT yet. That's a long feat that takes a lot of time, I'm sure, as you know. So, but when you're looking into ChatGPT is giving you tools to practice, right? Which is great. Traditional DBT, Marsha Linehan style, is group therapy and individual therapy at the same time. And so the group therapy, I think, is a really beautiful aspect of it because it really helps validate individuals who are having these experiences to know that they're not alone. But it's also just much more structured. And so when you're just going to ChatGPT and trying to get advice, or looking it up yourself, I still think it's helpful. But when you're going to like a weekly class, it's kind of like a class, the group therapy, and you're practicing it in real time. It's integrating it in real time and it's structured, and it's not something that you just do for a week or two. These modules, and the way that I did it at the clinic that I had experience in, where I'm going to be at actually in the fall, is 3 different modules, and each of them were 3 months long. And so it's good because it gives you several months of working through something and getting that practice, just like you would getting a degree or a course in school. And so that's what I find to be particularly special and helpful about DBT.
Interesting. Three modules, 3 months long each, 9 months. So one cycle for you is 9 months.
Yes.
Oh,
And
interesting.
individuals can do, like, for example, some individuals might just do 3 months. They might just do 1 module. Some of them might do 2. Obviously, it's recommended to do 3 because they're all different. So there's the three different DBT kind of like core skills. It's mindfulness, emotional regulation. And then also we're talking about, the actual distress tolerance tools, right? And so they're all going to be going over a different portion. So it's not little. It's a lot of work.
That's interesting to hear how different clinics do it. We had like a 6-month thing because we did like mindfulness between each ones, and so that's cool.
Every clinic does it. Yeah, every clinic does it differently, and I think it's also, it depends on the clinic. It depends on the person. Some clinics require you're doing individual therapy at the same time. Some clinics do not. But I think one of the, and I'm sure, as you know, too, one of the core attributes of DBT is doing that group therapy aspect of it. And that's very, very different than the individual therapy.
What about going back to the CPTSD versus BPD?
Yeah.
How do you know when a patient needs trauma treatment, right? Like, if I remember this in DBT, where sometimes they would be working with us in the DBT program, and then it was like, oh no, I think we need to, take a break and do trauma treatment. Have you dealt with that yet, or are you?
I haven't dealt with that too much, but I'm very much aware of what you're talking about. And it's something that people bring up a lot too on my platform. It's like, DBT I think is great, but everybody's different and how they operate and what works for them. And DBT, like I said, is not focusing on what has happened to them. It's just kind of skipping over that, being like, this is what we're going to do with it now, which is a totally different way of, treatment. For some individuals, it is really important to actually go through and process the trauma and process what they've gone through. I've seen a lot of people, EMDR with DBT, I've seen very, very helpful because it helps kind of process some of that trauma and give them the tools at the same time. So I definitely don't want it to come across like, it's DBT is perfect. It's a one size fit all for everyone. You don't need anything else. No. But if you haven't tried it yet, I think that I'm just a major advocate for people, trying out different things and seeing what works for them.
Yeah, that's really interesting. Doing it both at the same time, that would be so much therapy, and that would be a lot. That would be like all the feels all the time. I mean, that would be an intense.
That would be very intense, like very intense. And, sometimes that needs to be done before coming to DBT, right? Like, it's kind of hard to know, how to navigate and work through these things in your everyday life when you haven't fully processed some of the things that have happened. So I think that's definitely going to be dependent upon, the clinician and the patient and what, works best in that unique environment.
Yeah. What comes up for you? I think we were talking about this before, a different conversation, but what comes up for you when you work with these patients? Any of your old stuff, or the countertransfer, or whatever you want to call it? Like, what is it like? I hear very rewarding, which, yes, totally agree. What else?
Yeah.
What else does it feel like to work with this population?
Yeah. I mean, it's like, it is, and this is one thing that has been said by, when researching through like what DBT is and through Marsha Linehan's, through her work, is it's recognized that in the therapeutic relationship between the client and the clinician, they're shining a mirror on one another. And so it requires both work on the clinician and on the patient, because, and I think we talked about this briefly before too, a lot of people with BPD are highly perceptive, and they speak their mind. And these are wonderful traits, right? But it can be challenging, because you're not, you're in a very different dynamic there. And then two, the other part of it is as therapists, we always want to help. And it's not always that simple. It's not a clear path upward either. Sometimes healing is not always straight up. Sometimes it's a little bit like this, so it can be a little bit challenging in that regard. But I think it's just recognizing and also ensuring that I'm checking my bias at the door, during these relationships is crucial.
Yeah, that makes so much sense. I was just thinking back about the different patients that, I really, my bias is still like these are different disorders, CPTSD and BPD, but that might be I'm biased because I can think in my, when I look back on my caseload, I'm like, okay, that person had BPD and that person has CPTSD, and they don't feel the same. But maybe that's just, I read a research paper that said that people with CPTSD have more dissociation and like low mood, but they're more stable. And I was like, yeah, there were people who were they were diagnosed with PTSD. They definitely had motion dysregulation, numbing, as you were saying, problems with the relationships, but it was a lot more like very stable, but almost like too stable. It was like shut down. I don't, I do my stuff. I feel really lonely, but I can't get close to people. And when I do, it's really scary, but I'm just bummed out all the time.
Yes.
And then like I would feel their dissociation. Dissociation is like it's so contagious that especially when I was working in person with them, I would feel kind of a little spacey myself, but working with what I would think of as BPD patients, it felt more like, well, more, I don't want to say this in a bad way, but it felt more like being with a kid, right? It was like
Sure.
everything was on the surface. There was lots of up and down there was like a tenderness. I was pulled in. I wanted to hug them, right? There was a lot more like,
Absolutely.
I don't know,
Yeah.
sparkliness or something, but I don't know what you're.
Yeah. Yeah. I think what like comes up for me, and I want to make sure too that I'm like being clear that I don't think that they're the same. I just think that they're misdiagnosed a lot. And
Yeah.
so, but I think it's that,
Same. I don't know. Like, what?
yeah,
Anyway,
right.
continue.
It's like, again, like this is a big controversy, and so it's not black and white. We don't have all of the answers, but there is research that shows that around 40 to 50% of individuals with BPD also meet the criteria for CPTSD. And one of the fundamental things that I've seen be a difference that I kind of stick to is the identity piece, because individuals with BPD, a core trait is having changing identities, right? Typically around who they're with or what's going on in their life, or maybe they're not fully in touch with, who they are, their value system, and that fluctuates and changes as to where with CPTSD, that core sense of identity and who they are is kind of in place throughout. And then you also hit the nail on the head as well too, like from my opinion and my thoughts on it is also just a little bit more of that avoidance piece. Numbing out is more a trait of what I've seen in CPTSD as opposed to DBT, or sorry, BPD.
So many letters.
What am I saying now? So yeah, I agree. And that's just, my opinion as well. And just things that I've seen around in the research. But again, there's so much nuance to it. And also it is just kind of like, as long as individuals are getting the help that they need and the treatment that they need, I think we're missing the point having this debate on whether or not something should be BPD or CPTSD, right? Because it's kind of like we just treating the symptoms and getting the help and the correct treatment is the most important thing.
Totally. Totally. It's you moving into one of my favorite topics, what loved ones can do. Let's say if you're listening, you don't have these symptoms of any of the letters that were thrown out there, but someone in your life who struggles with emotions. Maybe they, go really up and down, depressed and happy, and they push you away, they pull you in. Like what from your personal experience or clinical experience, what can loved ones do? Like it's a hard position to be in.
Yeah. I think one of the most beautiful things loved ones can do for their partner and for themselves is have boundaries. And I think it's really hard because I think a lot of times, especially individuals who are in particularly romantic relationships or familiar relationships with individuals who might be struggling with this, it can feel like wrong to set boundaries, right? But in reality, boundaries are one of the most helpful things for individuals with BPD. And so I think taking care of yourself first and with kindness and with love, also recognizing that you can understand your partner's pain and still have boundaries around how things work for you as well is important. And then on the flip side, I think just not taking things so personally all the time from the person who's struggling it, right? Because I think as humans, it's really common for us to take things, I mean, it's about us. We assume everything's about us. And if someone's acting out, it's really difficult to not be like, wait, this isn't me. Like this person, they're going through war in their head right now and they don't know how to handle it. It's really hard to do that. And especially if someone has a tendency to say things that they don't mean. And again, I'm never going to justify that behavior, but I do think it can be helpful to take the pressure off of both people to just, realize that not everything that the person that is experiencing is personal to them. And also, like kind of how you mentioned before, it was like, if your husband, like back in the day, was like upset, it's hard to not take it personally, right? But just remembering, like, that's them. Like, we're separate individuals. That's what they're experiencing right now. I don't that in.
Yeah, those are really good points. How can a loved one, let's say you have a partner with let's say someone's listening who has a partner with BPD and they're like, got it, boundaries. But when I set boundaries, it's like an explosion,
World
right?
War III.
When you yell at me, when you insult me, I heard this recently. That's why I'm saying this. I go to a separate room and I take some space, and then the partner with BPD is like, that feels like abandonment. That feels like you are abandoning me. That is so hurtful. What do we do? Like, how can the person
Yeah.
navigate that and set that boundary in a way that doesn't come across as abandoning?
Yeah. That's really hard. And that's part of what I love so much about your work too, because you talk a lot about, individuals who are, supporting individuals with BPD, right? And it is tough because oftentimes like if there's threats of, self-harm or, having that sense of abandonment, it can be really, really difficult. But again, gosh, I really hope I don't misspeak, but I'm from what I've read and research is part of what is really crucial for working with individuals with BPD is not giving in to those demands. And it's helpful for that partner as well. And it doesn't seem like it in the moment. So I think that's like also a million dollar question. Like I don't recognize that it's a very difficult position to be in, but it takes work on both sides.
Yeah, I think that's
Unfortunately, right? Yeah, it's
yeah.
not just the person with BPD or the person with the intense emotions, and it's not just the job of the other partner to concede and meet all of their demands either. It truly has to be recognition on both sides.
Yeah, that is so well said. I am seeing a pattern that's either like the all or nothing, even from the partner. I am doing whatever they say. I'm saying yes. I'm validating and apologizing, and they can track my phone. They could, I will never, they'll say yes and almost like submit to anything to not upset their partner with BPD, or the opposite. They're like, this is too much. I'm done. I'm out of here. Bye. So having those boundaries and not giving into like, okay, fine, 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 fine. I'll just have no boundaries is important to have that like middle
Yes.
ground.
And that brings to another good point, also DBT for the family members as well, because it is the core attributes of BPD, right? Is that paradox of the black and white thinking, all good, all bad. What really helps individuals with borderline personality disorder is having that gray area. And I believe one of the best partnerships for someone with BPD is someone who can hold that gray area and be like, and reinforce that themselves and be like, actually, this happened, but it's not the end of the world or the relationship. And that's hard because the person, with BPD may be making these very like catastrophic remarks. If the other person doesn't give in and they're like, no, 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 wait a minute. I mean, this is not good right now, but it's not the end of the world. It's not good. And it's not all bad either. Having that sort of partnership, I think, can be really, really helpful, not kind of feed into that pattern.
Yeah. I love that. I love that even script too. It's like, hold on,
Yeah. So,
not the end of the world. Don't
like,
worry.
this sucks. I'm not going to say it doesn't suck. It sucks. This isn't good. I don't like it. But you're not a horrible person. I'm not the worst person. And the relationship isn't the worst relationship in the world. This is a moment that is not good. And we're going to work through it kind of thing.
I love that. This is a moment.
Yeah. A bad one, not a good moment, but
It's passing.
yeah.
Amazing. Anything else you want listeners to know? Like any messages or misconceptions or things that you've seen that you want to spread as far as possible?
Yeah, I just think the message really that I want to spread is just that nobody's broken. People don't need to be fixed, right? It's more about, being confident and learning how to work with the feelings that you already have, not changing how you feel, right? Not changing how you feel, but changing how you navigate them and kind of like doing that, just accepting that like we all have our flaws and there's nothing fundamentally wrong with you because you may think about things or view things or feel things differently than other people. And then the last thing I would say again is, my podcast, the whole premise of it is the Retired Good Girls Club, like helping women feel empowered to step in who they really are and stop trying to like fix themselves to fit in. And it's okay to take up space and make other people feel uncomfortable, especially if you're going to stand up for yourself. So that's important. And then, like I mentioned before, I'll send you the link for my DBT inspired workbook that just really gives us real-time tools that individuals can use in the moment, because we all like learn all this stuff. And then when we're in the moment, we're like, wait, what do we do? So having something there on hand, if anybody's interested, I have that as well. And that's really it. I just really enjoyed this conversation. It was just really inspiring and thought provoking, and I really appreciate it.
Thank you so much, Kaytlyn. This has been great. Like, both the conversations of going on your podcast and here, and tell everyone how they could find you. I'll link all of it in the show notes, but
Yeah.
just how can they find you?
Absolutely. Instagram is at not so dumb blonde _pod. And then YouTube is not so dumb blonde podcast. You can find me there. And then TikTok it's Therapy K. So I know there's a lot of different names there, but I can send it to you so you have it. And yeah, that's how you can find me. I post episodes weekly for Not So Dumb Blonde. I also host fundraiser events here in Denver for anybody who's in Denver. Yep. So you can hosting a coffee and comedy night that raises funds for teen and mental health awareness in the next couple months. Super excited about it. So you can check that all out there in my link tree.
Oh, that's awesome. I'll put all of that in the show notes. So if you hear any of this, please find Kaytlyn and go to those fundraisers. That sounds awesome. Thank you so much. It's so wonderful to have you. Thank you so much for listening, little helpers. I mean, if you want to support, all the what is it? Retired girlies? What did you say?
Retired good girls.
The retired good girls. Oh my God.
The chill girl anymore.
If you're a retired good girl, leave us a 5-star rating. Apple Podcast, Spotify. I don't even know what else this podcast is.
Any other platform that it could populate.
Leave comments, ask questions. We love you guys. We'll see you next week. Thanks so much, Kaytlyn. By accessing this podcast, you acknowledge that the host of this podcast makes no warranty, guarantee, or representation as to the accuracy or sufficiency of information featured in this podcast. The information, opinions, and recommendations presented in this podcast are for general information purposes only, and any reliance on the information provided in this podcast is done at your own risk. This podcast and any and all content or services available on or through this podcast are provided for general, non-commercial, informational purposes only, and do not constitute the practice of any medical or any professional judgment, advice, diagnosis, or treatment, and should not be considered or used as a substitute for the independent professional judgment, advice, diagnosis, or treatment of a duly licensed and qualified healthcare provider. In case of a medical emergency, you should immediately call 911. The host does not endorse, approve, recommend, or certify any information, product, process, service, or organization presented or mentioned in this podcast. And information from this podcast should not be referenced in any way to imply such approval or endorsement. Thank you.